All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So let's start our discussion. How was your weekend? John Snyder says showing 25 but no audio. Okay, can you hear me? Art Patron says, hello from Florida, the state with most sophisticated and intelligent governor in the US. Okay, excellent. Hello, Art. Jean Oliveira says, Texas, Meg prays that you're feeling better. Hopefully you're doing well, Texas. And talking about doing well, Margaret is doing well. She had her first dose, I think, about a week or more ago. Her side effects have now subsided. Her phone is still not fixed. So I was talking with her a couple of days ago, and she said that she spent a couple of hours with Apple's representative to try to figure out what's wrong with the phone. So that is going on with her. Generally, she's fine. Hello from Australia. Hello back to you as well. What has Australia done by blocking ivermectin? Their way of blocking that was also not very sophisticated. No, sorry, I'm not criticizing Australia. I'm criticizing the decision. Bill Berna, good evening back to you as well. Barbara, hello, how are you doing? How is Lotus? Pasi says, now we hear you. Thank you very much. Pasi, how are you doing? DDS, Doug, Gift. Excellent. So, what should we look at today? So, Guapo says, please discuss how DNA vaccines can continue to produce additional antibodies many months after vaccination. So, I have to actually look it up because I believe Johnson and Johnson has said that their vaccine would continue to make antibodies for a long time. I have to see the mechanism. That is it the piece of DNA, adenovirus, and the DNA then sitting in the nucleus for a longer period of time, or is it something else? I also wanted to share with you a quick discussion that some of my friends were having. So one of the friends said that it seems like, so they're all doctors. So one of them said, my class fellows, some not class, a professional doctors group in which I am as well. So one of them said that, hey, it seems like ivermectin is a very good therapy for COVID. And then another friend, who's also a doctor, became very upset, and he brought in the links that there are fraudulent studies there, and here is the study retracted, and so on, and there is no good study. And then another doctor started posting lots of studies themselves and the results of the meta studies, meta-analysis, and showing how it works, and then discussing how in various countries it has been working very well. And I was looking at that all. They know where I stand. They've watched my videos. And it was interesting for me to see that in professor level healthcare physicians, there still is this continuous discussion. Some think it works, some things it does not. So Guapo, back to you. Sorry. Yes, I will look into this one. So T Hunter says, have you seen that WVU is working on a nasal vaccine for COVID? So I know that there are companies that are working on nasal vaccine. I really like that idea. Barbara says, Lotus heard Luffy meowing and loved it. She's checking the computer intermittently and sitting on my lap off. So Luffy went upstairs after running around. And says they're following orders. Australia. So Keating says, have you heard of people getting chest pains after vaccination? Um, I have not heard of this specific chest pain, but chest pain can occur because of the cardiac inflammation. It can occur because of, let's say, any fluctuation in blood pressures. It can occur with any GIT disturbance. So there could be many reasons. So it can occur. M. Gregory says, it's Pisces full moon tonight. Luffy was acting up. Maybe. We'll see how many people act up tonight. Uh, Barbara says, did you see Dr. Corey today on Trial Site News interview? By the end of the interview, he was candid and cussing literally, and I agree with him 100%. So that is where we have reached. It is interesting that for Corey, I can't even believe it, the kind of pressure he must be under. I saw a video a few days ago where there was a MSNBC's host who was asking for um, repercussions and for the physicians who are saying that ivermectin should be taken. And the very first person they mentioned was Dr. Corey. Uh, then I think we all know how much pressure if I am under sufficient pressure, I can only imagine the pressure he has. And I think he is correct in his frustration that this is all data oriented, the things that are out there. For example, I was looking at my Twitter and I was seeing somebody just continuously uh, repeating the mainstream media's messages that ivermectin is a horse, uh, not horse paste, meaning it's a dewormer for animals. And then it is really dangerous for humans. It can cause toxic side effects and liver issues for humans. And if there is any effect seen, for example, let's say in India, that was just normal and natural effect of reduction in their cases that had nothing to do with ivermectin. And I don't argue with such folks. It's just very difficult. But there were some folks who were then arguing and talking, and they were going back and forth. And I was thinking that how strange it has become that we don't go to the fundamental. We have become stuck in the weeds, and this is the intentional confusion and mud that has been created. If you go down to fundamentals, the fundamentals are very simple. A physician should be allowed an off label use, number one. It is their and their patient's responsibility. They can discuss, they can decide to use it or not. Secondly, if a physician would see a result of some medicine, they would use it more often. So physicians are not silly that they would use it with their eyes closed without caring for any uh, observation for benefit or not. Thirdly, this medicine is very safe, more safe than many over the counter drugs. So, I think that then those who have been using it, they know how effective it is. And so, when they see that here is a very effective drug, and then they see how it is being stopped, then of course they would become frustrated. That here you have a number of people, you say, we want to protect you, but we are going to protect you in the way we think we should protect you. And that does not care for any other evidence. And so here is a problem that has been created. I thought, and I still believe in it, I thought people would drop their egos, they would become a good global village. They would come back together. They would talk with each other to say, hey, you tried this, it worked, let me try it too. Okay, I tried it, it didn't work, so maybe you should tell me more and observe more. So they would become that very close knit group to start helping. But this has become such a divisive time. And so Dr. Corey's frustration is understandable. And politics should not have come in it. So K. Molier says, let's see the COVID stats in Uttar Pradesh and Tamil Nadu. Let's see. Now I hope I can find that link. So if you just look at generally, let's say worldometer, coronavirus, and if you go to countries and let's go to India, generally, 33 million cases, 1.34 billion population, 33 million cases, 445,000 deaths. And here is the number of cases, new number of cases. At this peak, 379,449, something like that. And I was reading an article where somebody was insisting that this peak and its reduction has nothing to do with any therapy or vaccine or ivermectin or blah. They said this is just a normal, regular virus cycle. And the cycle goes up in 2 months and then it goes down in 2 months. And so there is a 4 months automatic cycle in this virus. And they said, well, this is just that cycle. So it has nothing to do with anything. I think there is a lot to be done. Medicine is there, ivermectin is there, vitamin D levels are there, social distancing or physical distancing is there, mask wearing is there, hand washing is there. When you see people falling on your sides, you would become careful. So there are then, albeit that we have less number of vaccination, but still 8-9% vaccination, that has its own benefit as well. So this is a mixture of all of that. And if you see here, the number of deaths have become very controlled as well. It is kind of not the best thing to do to just call it, this is our automatic, has nothing to do with anything else. Now, can we look at the numbers? I remember I had so I'll be ready tomorrow with the links to the states for India and look at them together. Now, hey Luffy, if I go to, let's say, US, US 43 million cases, population 330 million, almost what, 1/6 of India, 43 million cases, 694 unfortunately deaths. And to save you from my mouse's sound here, so we are once again in this strange time. And here, so US is not doing very well. It has not, we have not done well throughout. Sue has a very good question. Does death correlate with the obesity data? So Sue, I do not know if there is that close of a correlation there, but the studies have shown it very clearly, and I've discussed those studies, that folks who are obese, their risk is higher than others, than non-obese. Let's look at Israel for a second. Although we should go to Israel's own dashboard as well. So 9.2 or 3 million population, 1.2 million cases, 7,555 deaths. And look at this. So there is one more spike or wave. This wave is actually bigger than the previous waves in terms of the maximum counts. And if you look at the death rates, they are actually comparably higher as well. So maybe tomorrow we can look at Israel's own dashboard to see what is happening. I read a news that Israel may be getting ready for the fourth shot. Barbara says Luffy, Luffy. So the second one, Loofi. So Alquin says garbage in, garbage out. If analyze the raw Indian data, it is meaningless. Yeah, so we'll see if I can look at better data tomorrow. So Dave says, Dr. Bean, any way you can explain the difference between exposure and asymptomatic? There must be many levels of exposure. Very difficult to understand if asymptomatic people actually have the virus. So the difficult to understand meaning DDS says duck mouse. Yes, good that it is duck mouse. So let's see. Uh, Look for the asymptomatic. Of course, the problem with the asymptomatic is that here we have a person who is asymptomatic. That means they're not going to have any suspicion to say, I may have COVID, and then they are not going to go and get themselves tested. Because of that, we really do not know what is their percentages and what is their how did they manage to take care of the virus, unless we do random studies, and that is we stand on the side of the road and we whoever is passing by, we say, can we please have your PCR? And we ask them, do you have any fever? We check their fever. We ask them for cough and other things. Still subjective, but if we do that, I think Switzerland or Sweden had tried to do that once in Stockholm. So I think these are the kind of studies that would be needed to then say, out of, let's say, 1,000 people who were asymptomatic and we did PCR on them, and here is a percentage that was positive. Barring that, there is no way to actually say that they have the virus or not because they are asymptomatic. Eric Dog says, I call it revealing times. Yes, this unfortunately this has become a revealing time. I like the mouse quack. Duck says, very good, thank you. Luffy's office is just allowing you to use it. Absolutely. And he is very clear about that as well. He talks about it all the time. Rima says, how can they justify withholding such a safe med when people are dying? We are still saying no treatment until blue in the face. Yes, and so I don't think that they justify it by saying we would let a person die. They simply justify it by saying there are no strong studies, there are not sufficient studies, the toxicity is very high. So there is a set of um, narratives, there is a verbiage that has been formulated and that has gotten traction, and that verbiage has become stuck. And thank you very much for the super chats. So Bambi Secret, hey Bambi, how are you? Just seen a friend is off sick with a cold, sneezing and fatigue. In UK, the Zoe COVID-19 symptom study app has had a new symptom for a few months, but governor still says cough, fever, and anosmia. Government still says. Yeah, so this is very interesting. And I was talking about one of the patients that I managed a few weeks ago from Pakistan, and they're medical doctors, and they themselves did not suspect that they had COVID, and they had COVID before, so they were not suspecting that they would have it again. So the symptom set that they discussed, and I just happened to talk with them. I called them as students, and now they're doctors, and I called them for something else. And during that discussion, he said that I'm under the weather, I have cold. And I said, "What are your symptoms?" And he said, "I'm severely fatigued, I'm tired, I'm very, very sleepy. With that, I have runny nose and scratchy, painful throat." I said, "Do you think it might be COVID?" And he said, "No, I had COVID a few months ago, and then I had vaccine as well, so it is not COVID." So I said, "Do me a favor, get your COVID test done." So on my asking, he did get his test done, and test came back positive. Now his biggest problem was, in addition to all of those, he had anosmia as well. And so I asked him to take this Luffy thingy, and within 3 days, his anosmia was fixed and he was back to normal. Interestingly, last time when he had COVID, um, he didn't have he did have a drop in oxygen. It went down to, I think, 95, 94. This time, his lower respiratory system had no issues at all. There was no oxygen drop. But please remember, he had infection, he had vaccine as well, and now this was the third one. And we know that with vaccines, it is possible in many, and he's a youngster, 25, 26 years, actually 27, 8 years, that in youngsters, it is just generally milder, plus vaccine was there as well, so he had better outcome. So you are correct, Bambi, that now on one end, to me it seems, and I still believe so, that as the virus is going to more and more people, it is becoming more and more um, maybe contagious, but less lethal. That's what I think so far from the data. So it will have to become less lethal. It cannot just continue to become more lethal. It still has that time window. Bit, so here is the exposure and here are the symptoms. So between this time window is still something that can cause it to cause damage. This damage in some cases ends up in death, even if they are vaccinated or they had previous infection, or if this was the new infection. So there is this silent period, which couple of days now for this Delta variant, but that still gives this virus a chance to continue to spread plus continue to kill. Bambi says, "Sorry to hear about your friend, just shows that symptoms need amending. Professor Tim Spector, who runs the COVID symptom study app, is now doing research on the unusual sore throats with Delta." This is actually very, very correct. Thank you very much for articulating it this way. Unusual sore throats. A majority of the patients I am talking with, they say, "I have painful, scratchy throat, difficult to swallow, difficult to talk." Some runny nose. Runny nose was never part of this. It is a newer development for last few months. A runny nose, headache, anosmia has become very, very common. So you're correct, Bambi. Gut Vial says, "Deadly black fungus in COVID patients, mucormycosis. Is it a reaction to the remdesivir?" No, not necessarily. We have done this discussion many times. Usage of steroids, uncontrolled diabetes, and then maybe in some cases unhygienic practices, they all combine towards the black fungus. And I have done a couple of discussions. One, what is a black fungus? And number two, how to manage. How does your doctor manage black fungus? So please look at that. Lizzie says, what happened to the at the FDA hearing? So I actually really liked it. I wanted to talk about it. FDA hearing, did you see? So I'm going to give you a theory of mine. So what happened was, I think it was 16 to 2. What was the number? FDA's last briefing. FDA reject booster approval meeting. So I'm going to bring in this here. Give me 1 second. I should have CDC link, but anyways, advisor to the US Food and Drug voted in Friday to recommend COVID for Americans 65 and older, those at risk of severe illness. The panel, I think it was 16 to 2. So it is various ways to interpret this, that some said recommended, some said rejected. So here it is, by a vote of 16 to 2. So here is my theory. So you know that I rarely give my my opinion and theories. I mostly present data and discuss them. But here is my theory. I think that the two folks who stepped down before this meeting, the remaining group was, I think, careful. So let's say this was the remaining group. This is the, so now they're going to sue me as well, and they're going to send lawyers too. This is the remaining group. So I think that these folks were not comfortable with the data for the boosters. So they would have said that, hey, there is no point in having the boosters. And they probably saw that the rest of the group thought, or their bosses or whoever thought we should. And so they stepped down. But when they stepped down, they became the conscience of this whole system. So these folks over here could not just say, yes, approved, because they knew that if they did this, there are the two people who are going to speak. And they are already speaking now. So I think they became a check on the rest, and the rest had to then be more controlled. Now, I may be underestimating the rest, and maybe, as I had tweeted some of their comments, these comments are very, very interesting. That, for example, one of the pediatrician in this group said, no, I don't think that there is enough data to prove that it is useful, especially for the children or youngsters. And then I saw one more comment by the panel, someone in the panel, to say, we do not know the long-term effects of this vaccine. So I think that it was interesting that they came back and they said boosters are not yet recommended for everyone. So this is my little theory, that the two folks that resigned, they actually did not. Many people tweeted at me saying they resigned to go and get jobs in big pharma. My suspicion was that they were resigning because they were not comfortable with the way decisions were being made. And that is what I think with their writings as well. It seems like that is what was happening. Gina first says, do you think a person could develop antibodies if they get COVID but treated with ivermectin? Yes. Ivermectin does not block the vaccine's action. And because of that, vaccine can just continue on and work to get the antibodies done. Art Patron says maybe cats got kidnapped for two scientists told change vote, or the cats get it. Jody says, I like the FDA more now. I'm still annoyed with them, but not as annoyed as with CDC. So actually, I felt a little comfortable as well with the way they did it. So if you don't mind, forget about any political leaning. The FDA booster If you look at CNN, so please, my apologies, I had read CNN, so don't just write it off. There are a number of statements here. I hope I can see those statements. So look at this. The stated goal of this vaccine has been to protect against serious illness. So again, Dr. Paul Offit said, he's a pediatrician, and he said, well, we are not saying that this needs to go and prevent the disease. It should protect from serious disease, and that is what is happening already with the vaccine. So don't need to have the booster. So here is what is interesting for me. Pfizer doesn't care that people would take it as a failure of the vaccine if they continue to insist to say the vaccine may not work for longer. Number one. Number two, there have been studies. I have discussed studies that showed that when the antibodies wane, this is why I get in trouble. I talk these things. So, so check this out. So we know that the antibodies are produced, correct? For a few months, 4 months, 5 months, 90 days in some, eventually the antibodies would start waning. In majority of the immune behavior, for majority of the sickness, at some point, immune system says, do I still have the antigen? So let's say I got exposed today. My immune system responded with the antibodies. Now it is also seeing if the antigen is present. How is it seeing that? How is it measuring if the antigen is present? That is the macrophages and dendritic and other innate arm cells. Their function is to continuously pick up the cells that are sick or pick up the virus or bacteria that are running around, and they would pick them up and then they would release the cytokines. That is how they would tell the body that there is something going on. So now imagine when the virus has been taken care of, let's say somewhere over here in 15 days. Then ideally the macrophages and neutrophils and dendritic cells would reduce producing more cytokines because they don't see the antigen anymore. The result of that will be that those active adaptive arm cells, B cells and T cells that were actively fighting, that were producing antibodies, that were doing hand-to-hand combat in the cytotoxic manner, they would start to relax and they'll say, okay, we don't have more antigens. Plus, we also know that a B cell, for example, a B cell has to be bound to an antigen to be able to function. A cell will not function, B cell or a T cell, it will not function until in one of its hands it is holding the antigen. So imagine if I'm a B cell and you come to me and say, Mubin, make antibodies. And I am not holding any antigen in my hand. I will not make antibodies. I will not listen to you. But if I have an antibody in my hand, I know I have an antigen. I know I have an enemy. I'm holding on to it. Now, if you order me to say, make antibodies, then I know I should make antibodies against this enemy. So again, when we have taken care of the enemy, there isn't much enemy left there. Then these cells are just sitting there idling. And our immune system's behavior is that when cells are idling, they're not doing much, they would start doing apoptosis, meaning they'll start removing themselves. And they would say, you know what, we're not needed anymore. There are some memory cells that are produced, the remaining cells will die. When they will die, of course, there will be waning that would occur. Right? There will be waning that would occur. When that waning would occur, that is not an illustration or a demonstration or a proof that the vaccine doesn't work or the infection did not work. That simply is a proof that the immune system has gone to its resting state. Now, if the infection occurs, or you give another vaccine booster, for example, the body would, these cells, the memory cells would wake up and they'll say, what the heck, this antigen is back here, and they would start making the antibodies again. This is not a rocket science. The Pfizer folks know this as well. They are still propagating that yes, our efficacy is more, but it's not going to be more. It's not that they are intentionally saying our vaccine has failed. They just want to do boosters as well. They want to earn more money. Look at this. It's my opinion that we need this in our armamentarium, a booster dose now, particularly for the elderly and those with other high-risk conditions. But I share my colleagues' angst about the sparsity of safety data, said Dr. Mark Sauer, a professor of clinical pediatrics at the University of California, San Diego. Sawyer. So another person with a good comment. And I actually agree with this. Instead of saying just elderly over here, what really we should say is folks whose immune system may not be as active. That may be immunocompromised. That may be genetically immunocompromised. That may be because of infections, for example, HIV. That may be immunosuppressed because of steroids or other things, for example, with the organ transplant or with autoimmune diseases who are getting steroids and so on. And then uncontrolled diabetes is almost not exactly immunocompromised, but you know that it is difficult to manage infections in uncontrolled diabetes because the immune system doesn't work very well. Then senescence of the cells. Senescence of the cells is cells have become older and they don't function as well. So in all of such cases, it is, imagine that the two doses are actually not like two doses. They are not like another healthy person's two doses. These two doses are maybe like a single dose. And so giving a booster to start revving up the system or keeping it active is fine. But because this is already not causing as much of the activity of the immune system as it would in a healthy individual. So then so it is unclear that everyone needs to be boosted other than a subset of population that clearly would be at high risk for serious disease. Kurila said, it's not clear to me that the data we are seeing now is applicable to the general population. Again, a good statement. Then Dr. Philip Cross, Deputy Director of the FDA's Office of Vaccines Research and Review, noted that Pfizer was using data that had not been reviewed by experts. One of the issues in this is that much of the data that's been presented and being discussed today is not peer-reviewed and has not been reviewed by FDA. So they got this taste of their own medicine here, not peer-reviewed. But think about it, that they are presenting not peer-reviewed data, hoping it would work. Kurila noted that Pfizer's studies, and I hope I'm pronouncing their name correctly, apologies if I'm not, relied heavily on measurements of antibodies without looking at other important aspects of the immune response. Do you know which other important aspects? And have I not been talking about this for the whole 18 months now? That we have innate arm, and there is a function in there Natural killer cells are very, very important for asymptomatic management. We have then, let's say, the adaptive arm, which then has two arms. One is the humoral side, the antibody making side, and the other one is the cytotoxic side. And we have done this diagram multiple times, that it is possible that there is a percentage of the virus taken care of here, a percentage here, and a percentage here. And this could be, for example, maybe in one person it is 10% of the virus taken care of here, 70% here, 20% here. In another person, this may be 50% taken here, for example, kids, and then the remaining divided here. In other people, for example, some adults, it may be 20% taken here, and then 60% here, and 20% here, and so on. So that is what they're talking about, that we don't know which side of the immune system is doing what. So just saying antibodies there or not is not sufficient. It's a little disappointing that there's been very little reporting of the cellular immune response, and an entire focus on the neutralizing antisera, Kurila said. Immunologists point out that long-lasting protection comes from the immune cells called B cells and T cells, and Pfizer only presented data on antibodies response. What a beautiful statement. And we knew this. We knew these data points, that there is going to be memory cells and the natural killer cells and the T cells, memory cells, and it's not just the antibodies presence, it is the presence of these cells, these memory cells, that would define how our body would respond. And this is not a new science. This has been there for decades, this information. We are lacking data, including strong data on vaccine. Does that have been given, said Dr. Haile Gans, another pediatrician. So I hope CNN doesn't sue me, but here we are. They have good information here. So we are being asked to approve this as a 3-dose vaccine for people 16 years of age and older without any clear evidence the third dose for younger person when compared to an elderly person is of value. If it's not of value, then the risk may outweigh the benefits, and we know that 16 to 29-year-old is at a higher risk of myocarditis. I don't think we would feel comfortable giving it to a 16-year-old for all the reasons that everyone raises, and so on. So the point is, this was an interesting meeting. So Rizobit says, yes, and why is Pfizer only interested in antibody response and not safety or risk benefit? That's it. Look, Pfizer just want to sell their vaccine. Embol said, I saw a video of a guy saying that vax was causing a decrease in the CD8 cells, allowing cancers to grow. He was seeing more cancers in his work. So again, I do not know if there is any data around that. From a mechanism point of view, a vaccine, let's go to the mechanism for a second. So we know that the mechanism is, so he's presenting an anecdote. He's saying, this is what I'm observing. So there is no way for me to counter it or to recognize it. I have no idea. Maybe that's what he's seeing. But if you look at the mechanism, what we are saying is, here are the cytotoxic T cells. Here. These guys are the ones who would kill other cells. Correct? We are saying somehow the vaccine is going to reduce their count. That is generally not possible. Why is that not possible? I'll explain it. And this is an immune mechanism. You can go read it in immunology. And the topic to read will be proliferation and differentiation. Differentiation. You can just Google it and you can read about it. What happens is, let's say there is a cytotoxic T cell sitting here. This cytotoxic T cell is connected to another cell that is sick. So this cell is sick. It has the virus in it, and it is presenting the virus on its surface. And the cytotoxic T cell, CD8 positive cell, is bound with it. When it is bound with it, and there is the release of interleukin 2. So we know that there are T helper 1 cells here, correct? Which are this guy, T helper 0, became T helper 1 under the influence of interleukin 12 that came from the innate arm. Once the T helper 1 cell became active, it released interleukin 2. Interleukin 2 then worked on the CD8 that were bound with the antigen to become proliferated. That means they would increase in number. There is no way that there would be a vaccine that would reduce this proliferation and reduce the interleukin 2 production and reduce the interleukin 12 production. And that means the number of CD8 positive cell production should be normal behavior of the immune system. And whichever way a person's immune system is going to behave, some people are going to have more CD8, some people are going to have less CD8. On the other hand, similarly, some people would have more plasma cell or the active B cells, some people are going to have less. So for me, if I try to figure out what is the mechanism that would somehow cause CD8 to become less, the only way that could be is the following. Either there is an infection that kills the CD8s, HIV-like infections that attacks the T cells. So either there is some sort of an infection that just attacks this. So I don't think that vaccine has that. Or let's say there is a blockade of interleukin 2 production. And because there is not sufficient interleukin 2, there is not conversion of the CD8 cells to active proliferating cells. Now, I can't imagine why there would be a suppression of interleukin 2. What would be that mechanism? So if I continue to go backwards, so we have taken an effect to say less CD8 is what we want. And now we are creating causes. So one is directly kill the CD8s. Second is to give less IL-2 so that the CD8s are activated less. To make less IL-2, you need to suppress T helper 1 cells. To suppress them, you need to suppress the interleukin 12 production. And to suppress that, you have to tell the innate arm that, hey, don't worry about the virus itself. That is not going to happen. And then you're going to tell the innate arm not to worry about the sick cells as well. That is also not going to happen in healthy individuals. And then a similar mechanism is going to go on the other side too. So from a mechanism point of view, sorry for this mess on the screen, from a mechanism point of view, this message doesn't look correct, but from an anecdotal point of view or observation, maybe they're seeing something. K. Molier 504 says, has there been a study comparing reinfection rate of the COVID recovered and not vaccinated versus breakthrough rate of COVID recovered and also vaccinated? Yes. I believe that is the study which, when I discussed, got me lots of trouble because there were some quite passionate folks who became very, very angry with me. There are two studies. One is a study which is present on the CDC site. It is called Kentucky study, where they compared two cohorts, one with the infection and then reinfection, and the other with the vaccine and reinfection, infection, vaccine, reinfection. Then there is another study from UK, which was much more beautifully done. That study was done by UK's health ministry. That was done on a very large set of population, and there was a lot of data. Plus, it was not a no test study, meaning as they were studying people who were either infected and re-exposed, or infected, vaccinated, re-exposed, they were getting their PCRs, and if the PCR was positive, then they were getting their antibody levels, and they would just continue to monitor. They're still monitoring, and they'll continue to go on, but they had published that data as well, and that was beautifully done. And yes, basic answer is very simple in those studies. The answer is this: if your immune system at any point is active against SARS-CoV-2, either because of an infection or because of a vaccine. And please know, I always say infection can kill, so I never recommend infection. But infection or vaccine, whichever is the cause, if the immune system is in active state, then you are protected at that time when it is in the active state, unless it kills you because of the immune reactions. After some time, when the immune system has gone down, settled, reset, then the symptoms can reoccur, because there is a window of time between the re-exposure, infection, disease, and the time for the immune system to ramp up. Zen Solo says, someone I know recently had a fever with COVID-like health routine. Is black seed, vitamin C, vitamin D, morning sunshine, and honey normal doses? Interesting. So Art Patron Forever says, it's a good point you're making, and that is so much desire to have high antibody levels against SARS-CoV-2 because of fear of virus. What if having too high levels of antibodies for too long is also a dangerous thing not yet known? Actually, we know this. Too high levels of any antibody for too long is always dangerous. Dangerous, what I mean by that is our body doesn't like it. And again, please don't take this statement as an anti-vaccine statement now and say, Mubin said this. The point I'm discussing is a more mechanism, and that is this: if our cells continue to make antibodies and just keep making them, they would pour them in our tissues and in our blood. That would make our blood more viscous, more thick, less able to move better. And we know that there are conditions where there are more proteins or less fluids in the blood, and blood doesn't move correctly, and that is a huge problem. So similarly, if we have too many antibodies presence causes the macrophage activation. These are called the biological actions of antibodies, not just the attacking part to the antigen. Complement activation occurs, macrophage phagocytosis occurs, antibodies can settle on tissues and then cause activation of the complement and other things and cause local damage. So antibodies, excess amount, longer period of time are not useful. But our body is good enough to kind of curtail it and stop it. No. So there is a question. I'm not even going to show that question, but no. Uh, Gina Tulip says, can you explain again what is antibody dependent enhancement? It is is it the cytokine storm? So number one, it is not the cytokine storm. Number two, I have done in detail the enhancement. Generally, the idea is this. They say, the folks who call about ADE, with SARS-CoV-2, we have not seen ADE. So anybody who says SARS-CoV-2 shows ADE in humans, they have to show data and studies, because there is nothing proved. This anecdote that I observed, the cases going up, I think it is ADE, or cases going down, I think it is ADE. I think that's an observation. It doesn't say ADE until you can show that in data. But the idea of the ADE is this, that when an antibody is attached to an antigen, it's a convoluted theory in this way that it is actually an incorrect theory. So I'm going to try to give it a lot of provisions to make it correct. The first part of the theory is that somehow this antibody is non-neutralizing antibody, which means that, for example, if it is a virus, let's say this is SARS-CoV-2 and its spike proteins. This antibody is not able to connect with the SARS-CoV-2 in a way to obstruct it from binding with the ACE2 and entering the cell. It cannot. This antibody is attached to it in a way that the virus can still bind with the ACE2 and it can still get in. So that is the first provision for this. This is what they say, loose antibodies, non-neutralizing antibodies. Then they say that not only this is a problem because infection would occur, the second problem is that the antibody and antigen complex will then sit on a macrophage, for example, bind with the macrophage, and then this complex will be phagocytosed in the macrophage, which is a normal mechanism. But once it is phagocytosed, once it is taken in the macrophage, then this pathogen, the SARS-CoV-2, will escape this phagosome and infect this macrophage and then get out and infect other things. Again, this is not a correct mechanism for SARS-CoV-2. The reason for that is when the phagocytosis occurs, when the antibody antigen complex is taken in the macrophage and a phagocyte is formed, a closed stomach is formed, and when the lysosomes are connected here to kill this pathogen, there is no mechanism known that the SARS-CoV-2 can escape this jail. There are pathogens that can escape this. For example, Bacillus anthracis. When Bacillus anthracis, the one that causes anthrax, when it is phagocytosed and it is in this phagosome, this stomach, and when we pour acids on it, who pours it? Dendritic cell or macrophages. It is mostly with the macrophages that the problem is. When the acids are poured on the Bacillus anthracis actually uses those acids to become active. And when it becomes active, it comes out of it and then infects it and then goes out and causes more infection. More macrophages would eat it up. They will become sick as well. And the process continues. And either you stop it or the person dies. SARS-CoV-2 doesn't have any such mechanism. It doesn't have any enzymes that become activated on acidification, which allow the SARS-CoV-2 to escape the phagocyte and then cause infection. Then there are more mechanisms. In theory, This is one. Then there is also a possibility of complement activation, and then the complement binding here, which causes the other phagocytes like macrophages or dendritic cell to come and pick up this thing, this complex of antigen with the complement, and then that infects the cell. Again, this has not happened with SARS-CoV-2. So good mechanisms in theory, but has not been observed. And this is not the right thing to say that somehow vaccines promote this. There is no such mechanism. How would a vaccine do this? I have done this discussion in detail that if this happens, then if it is infecting the cell, then that is normal infection. If the vaccine was there or not there, that is a normal infection. So, okay, fine, let's say vaccine failed, but there is no enhancement in here. This is a normal infection. I think that vaccine, let's say this is happening, which is not happening, but let's say this is happening, then vaccine is still causing obstruction. It is still making it more difficult than for the virus to just directly bind with an ACE2 and get into the cell. Vaccine is still sitting in there, the antibodies are still sitting in there, causing a stalling and hindrance with the binding. So how is this enhancement? This is actually disenhancement. We should call it antibody dependent reduction in enhancement, reduction in function. Then similarly, if you go down here, they say this is also antibody dependent enhancement because the macrophage is eating up by holding the antigen antibody complex and then eating it up. Well, that is a normal function of the macrophages, to pick up the antigen antibody complexes and phagocytose them. This is, let me show you here. If I go here and I say phagocytosis of antigen antibody complexes. See, phagocytosis of immune complexes. And this is a normal, this is one label I always forget. This is the coating of the immune system, coating of a pathogen with complement and with antibodies is called, my brain is weird that if I do not learn something, I just cannot recall it ever. If I once don't recall it. This mechanism is called antigen antibody complex making it easy to phagocytose. What is this called? Opsonization. So someone here in Cool Beans, please remember opsonization. Whenever I say which one is the one that I forget. So opsonization is the process. You can go and see here again. This is a copyrighted material here for people. But opsonization means, so check this out. This is an antigen, this blue thing. It is coated by the antibodies, and then these can cause, the antibodies can now act as grips on the pathogen, and macrophages or dendritic cells can now hold with the antibodies and eat them up, and then phagocytose them and destroy them. And then the folks say that somehow this is enhancement. No, this is not enhancement. This is how macrophages clear the immune complexes. This is their job. And so, sorry, there is no ADE observed yet. And I have discussed 5 mechanisms of ADE, what infections can actually cause that or has been observed to do it, what kind of setting in which this was observed, in vivo or in vitro. So please just look at that previous video. Okay, so I had been going on with my little rant about the ADEs. Okay, so yes, yes, yes. Texas Meg, you're correct. Opsonized. It becomes opsonized. James Nguyen says, Dr. Mubin, maybe you're just getting old like us. Absolutely. So this is from ever that if when I'm studying something, if the very first time I don't catch something, I would never be able to retain it afterwards. And opsonization I studied when I was in second year medicine. This was 1990 or 89. And I know all the remaining mechanisms. This one process is a very common process. There is a complement dependent opsonization, there is an antibody dependent opsonization, but I always forget this word. Okay, cool. Let's do one more question and then we stop. Jerry says, very impressed with Dr. DeMello's talk. Please discuss why colchicine is not in FLCCI mask and should it be added. So, of course, I think that FLCCC have their own way of figuring out what goes in, and they have a panel and they discuss the mechanisms and then they discuss how to use it. It might show up on their uh, protocol at some point. What I see is many folks, the doctors that I am in contact with, they become a little nervous with colchicine because of its side effects. Because colchicine is a drug um, that would make the immune cells less active by breaking the microtubules or blocking the microtubules. I hope we know what is the mechanism. Colchicine's immune mechanism, that is it. So let me last one point and then we stop. It's a beautiful thing. Imagine this is a bag, just like a normal bag. Like let's say this this little envelope I have, right? So inside the bag, this is a cell, and the cells that need to move, for example, immune cells, they have a very interesting mechanism to move. What they do is they have microtubules. Imagine these are like little sticks, and there are many microtubules that are present in the cell. Now, let's say the cell wants to move to this side. And what dictates the cell should move to this side? Imagine there is injury here in the tissue. When there is tissue injury here, that injury would cause broken chemical substances to be released from the broken tissue, from the immune cells that are already there, and they would make some chemical substances. So all of those cytokines, chemokines, and the broken cell structures, they act as chemotactic factors. What does that mean? These broken things would spread from there all around this area of damage, and they would spread out like this. And in the immediate vicinity of the damage, there is going to be more concentration of this damaged particles. And as you go farther and farther, there is lesser concentration. This is like, those hunters who catch birds by putting the seeds, and then the bird would continue to walk, and there are more and more seeds, correct, till the bird reaches the place where they want to catch him. That is the same thing that happens with the cell. Imagine the cell is a bird. What happens is around the cell, there are chemical substances. So imagine there are chemical substances all around. The cell can figure out where is more concentration. Wherever there is more concentration and it can sense it, the cell would decide to move in that direction. Now, to move in that direction, How would it move? What it needs to do is it needs to protrude a finger in this direction and then move in this way, then protrude more finger in this direction and move there, and then more, and that is how the cell has to do. So how does it protrude in this direction? It takes these microtubules and it pokes them in its own little membrane. So imagine if this glove in my hand was the membrane and the cell is making microtubules inside, it would poke them and that would move the cell membrane in that direction. And then once it has done it, then these microtubules that were done, they will be broken down, reassembled, and then poked again. And they would be, so microtubules are everywhere. They would be broken down from this area so the cell can move in this direction. Then more microtubules will be made, poked here. The cell membrane would go this way. These will be broken down from here so the cell can continue to move and move and move till it reaches this area, and then it sits down there and starts functioning. This process of movement is done with the microtubules acting as little fingers to poke the cell in a specific direction. Colchicine blocks this movement by interfering with the microtubular structure building. So when the cell cannot build microtubules, it cannot poke in a specific direction, and now it is not working. So because of this, lots of immune system and any cell that is moving about, its function can actually go down with colchicine because colchicine would make them immobile. In addition to that, many of our cells, without having to move, they use the microtubules for their internal functions. So for example, let's say this is a cell. In this cell, it wants to send this substance A from here to here. So let's say substance is X, point A to point B. How does it send that within the cell? How does it send that substance over there? The cell is not just a fluid thing that the substance would just have to swim to the other part and go where it needs to. The cell would actually make a highway from here, point A to point B. This highway will be made with microtubules. Then on the microtubule, cell would attach a motor. This motor is called kinesin, and I'll show you kinesin in a second. Then it would hand this substance to this motor. Motor would grab the substance and walk on this highway till it reaches the end of microtubule, and then it would release the substance. Once that is done, this microtubule will be dismantled and it would be built for something else. So imagine every day you have to go to your office. We develop a road for you from your home to your office. Once you are in the office, we dismantle the road and we use that raw material to build a road for somebody else. When you say in the evening that, hey, I want to go back home now, we once again make a road for you from office back to your home. And then once you have reached home, then we dismantle the road again. That is what cells' internal substance trafficking is done this way. So let me show you. If I say kinesin moving substance video. So I wish I do not accidentally pick up somebody's copyrighted material.
Just like a busy city, there's constant motion inside.
So give me 1 second. I'm going to show you kinesin. So do you see that this is the microtubule here? And on the microtubule this is the kinesin, this is the motor that is sitting, and it would hold on to some substance and use it to move from one point to another point. So look at this. It is using energy, ATP, and it is actually walking on this road. So I'm going to stop here. So these are the feet that are walking. And for each walk, it needs energy. It takes ATP and uses it. So it asks for cash. And so for every step it takes, it says, give me money. And that money is phosphate. Once it takes the money, it moves and it is holding on to the substance and it is moving that substance from point A to point B in the cell. So it is so funny. Substance don't just osmose from one point to another or diffuse. They do that too, but majority of the time when there is a deliberate need to move the substances, kinesins and dyneins and these things come into play. So colchicine interferes with that function. That means it can actually interfere with a lot of our body's functions, not just for the immune system. Because of that, there is a possibility of the side effects. So as long as the doctor is very, very much on top of the medication, they know what medicine, what dose, what side effects to look for, what is a safety therapeutic window and all that, then it is interesting to use it. Otherwise it can become hazardous for someone who starts using it without knowledge. Okay, so with this, thank you very much for your time. I hope that you had a great weekend. Thank you once again. Please do me a favor. Please like, subscribe, and share as long as this channel is up. I think it would stay up, but who knows? And if you would like to support this work, there are some links in the description. You can buy me a coffee, or you can be a patron, or you can use PayPal to support this work. Thank you very much, and I'll see you tomorrow. Tomorrow might be a little bumpy because I'm going to try to work on Odyssey tomorrow. Okay, bye-bye.